Good morning. Thanks for getting up. I'm going to talk about clotting abnormalities, which present as a prolonged PT or PTT. Sorry to have to do this early in the morning. I'm going to do a case-based approach to the problem and sort of go over, really review sort of how to approach that problem or the problem of bleeding in general in a patient. I do have a couple of disclosures here, although none of them are at all relevant to what I'll be talking about. So here's my agenda, and I'll move relatively quickly. Just a review of the workup. First case is an asymptomatic patient with a mildly prolonged PTT. Case 2 is not such a minor abnormality. It's actually an elderly woman with a very prolonged PTT who requires anticoagulation for AFib. Case 3 is a young male with a marked prolongation of the PT. Cases 4 and 5 are patients with a mildly prolonged PT and PTT. And finally, the issue of the minimally prolonged PTT and clearing those patients for surgery if, in fact, they've drawn a screening PTT. So can't talk about this topic without just lubricating the neurons about how the clotting factors are, what the PTT measures in terms of the contact factor, the intrinsic cascade coming together in a common pathway, fibrinogen to fibrin, and of course the PT, the extrinsic pathway. We do have some other tests, the thrombin time in particular, that can be used to assess fibrinogen to fibrin conversion. And finally, there is another clotting deficiency, factor 13, that's not reflected by prolongations in the PT or PTT in terms of forming a stable fibrin clot by the action of the transglutaminase factor 13. And those patients, of course, will have a normal PT or PTT. It's quite rare. So this is the crib sheet. For sake of time, I'm not going to go through it, but many of the cases will kind of illustrate it. Some people get baffled by the people who have a prolonged PT and a normal PTT, and really there's only one inherited problem, factor 7 deficiency, or you can have factor 7 deficiency that's somewhat more selective than deficiencies of other factors due to early warfarin use in particular, liver disease early, and of course vitamin K deficiency. Then normal PT, high PTT, basically the hemophilias, contact factor deficiencies of deficiencies or inhibitors of various types, and of course heparin. And then of course if they're both high, you can have common factor deficiencies as well as a variety of disorders, including DIC, more advanced vitamin K deficiency, liver disease, and finally, of course, as I mentioned, factor 13 deficiency. So I think it's very important I like to say, to evaluate patients and not lab tests, and particularly when you get a consult to clear a patient with clotting abnormalities. So the best screening test for bleeding is personal and family history, including the location of bleeding, basically be able to withstand surgical procedures and not bleed, going through women, menstruation, childbirth, whether they required a transfusion. To me, that's a very important bar because a lot of patients come to you, they say bruise, and so forth, and of course medications, particularly aspirin, NSAIDs. But the important thing to remember is screening laboratory tests are in asymptomatic patients have not been shown to be predictive of bleeding. So the history can perhaps be extremely reassuring if they've been challenged. So why even bother doing any testing in asymptomatic patients? And this has undergone changes, I'm sure, depending on SOPs at your center, whether they do routine screening tests in patients with no history. Certainly people undergo very major surgery, neurosurgery, and TGU, and no prior history of major hemostatic challenges. It might be prudent to consider screening, but again, depending if the procedure is very minor, maybe that's not required. An older patient who's never had a major surgery, who might have developed an acquired hemostatic defect. It doesn't occur very often, but God forbid somebody might have an early acquired factor VIII inhibitor and bleeds excessively post-op. Sam Rappaport, one of the premier people years ago wrote a paper about this being a backup for absence or poor history taking to do testing, medical legal protection. But I dare say you get into more trouble in medical legal if you order tests that are abnormal and don't do the appropriate workup than not doing the tests at all, in my view. And then, of course, sometimes SOPs demand that they be done. So let's jump into the cases. I'm going to go pretty quickly, but some of these are kind of bread and butter. So this is a 28-year-old female referred for a prolonged PTT found during a workup for menorrhagia. Her past medical history is unremarkable, no bleeding post-wisdom teeth extraction or laparoscopic surgery for endometriosis. So she's not a bleeder in terms of procedures, but of course she has heavy periods. One of the things always to think about is von Willebrand disease, she did not have this, but her PT was normal, but her PTT was very prolonged at 87 seconds. So what's the best way to approach such a patient? Testing for a lupus inhibitor right off the bat, doing some of the specialized tests like dilute RBVT, Russell Viper Venom, giving vitamin K, administering FFP, or ordering a mixing study, also known as inhibitor screen. So what I would stress is a methodical approach to prolongations of clotting times is the best approach, and getting a mixing study can still be very useful in terms of elucidating what's going on and not being misled by doing laboratory tests that potentially might be misinterpreted if you don't do a proper mix. So a mixing study, very old test, take the normal plasma, patient plasma, and the classic one-to-one mix them together. And generally it's done on the PTT, but occasionally you can do it on the PT. And you not only do an immediate mix where you measure the PT or PTT at 0 time after incubation, but you carry it out to 2 hours in general by doing serial measurements of the mix at 5 minutes, 30 minutes, 1 hour, and 2 hours. So if you get complete correction and it stays corrected, you have a factor deficiency. If it doesn't correct, you have some type of inhibitor, which either can be a lupus type inhibitor in which the PTT does not correct and generally stays pretty flat over the 2 hours, or a factor inhibitor where it prolongs progressively out to 2 hours. So this can be very useful in making a first distinction between those two. So the best answer in this case was a mixing study. The mixing study corrected completely, remained corrected, and then you do individual factor assays, 8, 9, 11, and 12, although you might guess that it's probably up here since the patient's not a bleeder, and a female, not a male, who might have hemophilia, and in fact, factor 12 is 14%. So factor 12, very prolonged PTTs in vitro, but no clinical bleeding. Also the same scenario goes for deficiencies of high molecular weight kininogen or prekallikrein. These factors are not required for in vivo hemostasis and requires absolutely no treatment. Let me jump to the next case. These are all actually real cases. This is a woman I saw about almost a year ago now, an 85-year-old woman of Ashkenazi Jewish ancestry who actually had survived Auschwitz. She had presumed factor 11 deficiency, and she was referred by our cardiologist for consideration of anticoagulation for atrial fibrillation. She'd lived in Florida for many years, underwent multiple surgical procedures with excess bleeding, maybe following one of them a sinus surgery, and she'd had sometimes received FFP. So she moved to Boston, and she was referred to me by the cardiologist. She had paroxysmal AF, and her PTT was 113.7 seconds, very prolonged with a normal PT. And we did a mixing study, and to our surprise, it did not correct at all. It was 112 seconds, and exactly the same number at 2 hours. Really with something you might see with an inhibitor screen, with a lupus inhibitor. So the inhibitor screens consisted with the lupus perhaps, but the DRVVT and silica clotting time were negative, so your confirmatory tests are negative, but I have to be a little careful because maybe she does indeed likely have factor 11 deficiency. That's the diagnosis she was carried. We did some ancillary tests to make sure she didn't have other markers, perhaps, of antiphospholipid antibodies. They were negative. And then we go to the lab and start doing factor assays. And in fact, her factor 11 is extremely low at less than 1%. But her factor 8, 9, and 12 are all normal. And in fact, there's a dilution-dependent pattern with those factors, kind of what you see with a lupus pattern if you do progressive dilutions in factor assays. So the question I was faced then was, does this woman truly have factor XI deficiency? Does she have some type of an inhibitor, a lupus, or maybe even an acquired inhibitor of factor XI, given that she was infused with plasma, or does she have both? So fortunately, we have some tools to certainly address definitively that she actually is factor XI deficient. So they're actually, you can order a send out for their couple of very common mutations in Ashkenazi Jewish patients. She's homozygous for an E117X mutation, which actually leads to a nonsense mutation and truncation of, so she actually is homozygous. So she clearly has hereditary factor deficiency of one of the typical types found in Ashkenazi Jews. But what about this inhibitor? Is it non-specific or specific for factor XI? And the lab is really unable to do Bethesda titer against factor XI because of the potency, perhaps, of a lupus. Well, you're left with a decision. The woman's not having bleeding, fortunately not having procedures, and to me, this becomes a matter of common sense. She survives Auschwitz. She has this bleeding problem, potentially. You recommend no anticoagulation. So a few comments about factor XI deficiency. It's the only contact factor deficiency associated with bleeding. High prevalence, as I mentioned, in Ashkenazi Jewish population, about 1 per 1,000. Patients may present late in life with no prior bleeding history. Heterozygotes, about 15 to 60% levels. Homozygotes, usually less than 15%. And about a factor XI deficiency, the bleeding is highly variable, even among those with severe deficiency by numbers. The levels don't necessarily correlate with bleeding. And what you would require for hemostasis is about 20 to 30%. So it's very variable. But the biggest problems, of course, were they to undergo ENT or GU procedures if they have this disorder. Management would be FFP if you need to use it, plus potentially using adjunctive Amicar. Fast forward 9 months. In March, I get a call. 9 months later, she's admitted after falling at her home, sustaining a big periorbital hemorrhage. She's transfused with 4 units of FFP with no increase in her factor XI level. She develops bradycardia and requires emergent placement of a pacemaker. Fortunately, despite the bruising, she didn't have any visceral bleeding, no intracranial bleeding. She did fracture a patella, but now she had a very long bradycardic pause and needs a pacemaker. So what do you recommend? Fortunately, you'd worked her up. So what do? Plasmapheresis her to remove her inhibitor and raise her factor XI level to really give her recombinant 7A pre-op, not FDA approved, but there is some experience. No prophylactic hemostatic support and keep 7A in reserve, or start immunosuppression, infuse FFP, and delay the procedure. So that was the decision I was faced with. And we actually elected not to give her anything. I mean, this woman really didn't have that much of a bleeding history. Yes, she fell and bruised herself pretty badly, but in the hospital she was stable. And despite the FFP, which resulted in no rise in levels, so I thought she likely actually does have an inhibitor factor XI. She does, but why did I not do anything? Well, 2 things. First, I called the cardiologist and said, tell me what this procedure really involves. And he says putting in a pacemaker is relatively bloodless. And the second thing is this woman went through life really without much bleeding. And even if she has factor XI deficiency, not much bleeding, then inhibitor won't necessarily hurt her because she really is not that much of a bleeder. So, in fact, fortunately, she did very well with no excesses of bleeding. So I think a lot of here some intuition and common sense comes into play in terms of how to manage such a patient. So isolated prolongation of PT. This is a 21-year-old African-American male, requires clearance to play varsity athletics. He has no bleeding history. He recently underwent an emergency appendectomy without bleeding complications. There's no family history, but his pre-op screening prior to appendectomy showed a normal PTT and an elevated PT 33 seconds in INR, but he went through the appendectomy with no problem at all, with no bleeding. So what's going on here? What does he have? 11, vitamin K, factor 7, taking warfarin. So we come down right here in terms of factor 7 deficiency. And so in fact, his level was less than 1% of normal. So this patient does have factor 7 deficiency. It's uncommon autosomal recessive disorder in terms of its clinical expression. The levels, again, don't correlate terribly well with bleeding, but a little bit better than factor 11 deficiency, but not nearly as well as with the classic factor 8 or factor 9 deficiencies. There are some patients with very low levels can have severe bleeding, but usually if their levels are over 10%, they get by, might have problems in major surgery. There are many genetic defects identified because this is autosomal, so there's a possibility of double heterozygosity. So there are variants actually with markedly reduced factor 7 activity when you use animal thromboplastins, which were very common in the older days, particularly rabbit thromboplastin for the PT assay. Many labs now have switched to human, but you might occasionally still get a lab that uses. So this was patient presented in the days when the labs were still using rabbit tissue factor routinely for their PTs. And so his patients had been, PT-INR had been determined using a PT reagent containing rabbit thromboplastin. So in fact, when you used the rabbit tissue factor to do his factor 7, he had a very low level. But in fact, his level when you used a human thromboplastin was more normal. And this variant actually was identified a number of years ago in Italy and the term factor 7 Padua. It's actually been seen in a fair number of African Americans with factor 7 deficiency. So actually, I could actually feel relatively comfortable actually clearing this patient given his level with human to actually, he was actually a football player, although somebody might still have some concerns maybe with a 36% level that he had, but nevertheless, that's what at least I reported to the sports facility he was at. How would you treat such a patient if you needed to? Obviously, this patient I don't think needs to because, again, 20 to 30% is usually hemostatic, but if the level's lower, 7A is actually approved recombinant 7A for factor 7 deficiency, along with, of course, inhibitors to factor 8. The doses are usually around 20 to 30 microgram per kilogram every 6 to 8 hours, or you could use FFP. Case 4, patient with a prolonged PT and PTT, 24-year-old fellow referred for evaluation prior to nasal surgery, a septoplasty. He'd sustained fractures during sports. He really had no family history of bleeding, but he himself had some minor bleeding, gum bleeding with dental cleanings, easy bruising, no medications. Screening labs are normal, including his liver, CBC platelet count, and he has both a prolonged PT of 17.8 seconds and a PTT 41 seconds. So most likely diagnosis, we're in the common pathway now. So which of these would be a common pathway deficiency? Fibrinogen would be one of them, or of course there are others, factor 5, factor 2, factor 10. This, of course, is intrinsic pathway, lupus anticoagulant, typically an isolated prolongation of PTT, and then factor 13 deficiency, they'd both be normal. So that's the answer, and we do some then secondary labs and measure a thrombin time, which is quite prolonged, which could be the case in a hypo or dysfibrinogenemia, and then get a specific assay for fibrinogen. The clottable assay, which is routinely the fibrinogen we get, is low at 41 milligram per deciliter with a normal of 200 to 450. His reptilyase time is also very prolonged, again, measuring the ability to fibrinogen to fibrin. And then you order a specialized test to measure how much fibrinogen antigen protein is there, and it's 223. So this is elevated relative to the relatively low clottable fibrinogen, really indicative of so-called dysfibrinogenemia, an abnormal fibrinogen molecule. So that's what he has. We actually tested one of his parents who also was a carrier of this abnormality, and this is an autosomal dominant disorder. So how to treat this fellow? He's undergoing an ENT procedure. His level of functional fibrinogen is pretty low, so I'd like to give him some prophylaxis. I don't want to risk bleeding into the airway. So for major surgery or trauma, you could replace with either cryo or there's actually a number of specialized clotting factor concentrates that are out there. There is actually a fibrinogen concentrate, Riostap, plasma-derived concentrate, but virus safe, approved for afibrinogen and not for dysfibrinogenemia, but we actually used this and got approval. It's actually a compendium use to actually use it for dysfibrinogenemia. Gave him one dose before the surgery, and he just did fine. Another patient with a prolonged PT and PTT, 76-year-old man, referred for clearance prior to total knee replacement, no personal or family history, multiple major surgeries without bleeding, very helpful. Social drinker, a couple of medications he's on, typical for an older patient. His screening labs, liver function, CBC platelets, creatinine are normal, and his PT is slightly prolonged at 14.4, his PTT at 40.8 seconds as well. So what's the most likely diagnosis? 11-7 lupus inhibitor, factor V deficiency. Now we're in the common pathway, so the only one of these factors that's in the common pathway is factor V. And then we do additional studies. So they actually did a mixing study which corrected completely and remained corrected. But I'll come back to problems of doing mixing studies when your prolongation, particularly your PTT, is not at least about 5 seconds. There's not a big delta to correct off. So many labs, including our own, will not do mixing studies if the PTT is not 5 seconds above the upper limit of control. So you measure specific factors in the common pathway. Fibrinogen's normal, 5 is 29%, the 2 is 122, and the factor 10 is 122. So he has factor V deficiency, probably a heterozygote. Levels of 25% are normal for hemostasis, 20 to 30% for these factors. For 8 and 9 in severe hemophilia, it's 50%. You need levels over that. That's why you need to get 8 and 9 severe hemophilias for major surgery up to peaks of 100 and keep the trough over 50. For very severe deficiency, you could use FFP. Occasionally, there's a pool of factor V and platelets that you might need to use. But this patient had no bleeding history, had gone through procedures before, so he could be cleared again. So let me discuss one final issue, which I think has really become quite common and become quite annoying. I don't know whether many of you have had this. It's the hematology consult for clearing a patient with a mildly prolonged PTT for major surgery. These are usually people with no bleeding history. So you repeat it, and the problem generally will not go away. And then you do a mixing study. But as I remarked, if you don't really have a real prolongation that's at least 5 seconds, reliable interpretation is difficult, and you get a lot of borderline results. So I saw a lot of this for many years at the VA, where we have a wonderful medical record that goes back, and you can look at old PTTs. So I have 2 different approaches to this problem, again, if they're not a bleeder. One is algorithmic approach based on the PTT value. If it's over 41 seconds, you do a mixing study, draw some extra blue tops, freeze the plasma, send it to your coag lab if you have in-house capabilities, and then do an algorithmic, a logical approach based on the workup if they could do a mix. Obviously, if the mix is not prolonged, then if you send the samples out to Quest or one of your laboratory vendors, the shotgun approach, where special coag, where you can't have this option of freezing samples. You order a mixing study, you order a lupus anticoagulant panel, and you order 8, 9, and 11, because they're really the only factor deficiencies causing a prolonged PTT that will lead to excessive bleeding. And I dare say if a surgeon calls you, we have this case, we want to do major surgery, our PTT is prolonged, and they call you the day before, you say, sorry, I can't clear that patient because, we really need to do the workup. If they're dumb enough to order the test and it's not indicated, they're stuck with the consequences of it, and I would tell them it's elective surgery. You should have called me a month ago before a day ago. So this can often be a frustrating, inconclusive exercise. A widely used coagulation instrument reagent appears to be more sensitive to these minor abnormalities. And if I look back in my records on some of these patients, I have found a normal PTT prior to 2010 when a new coagulation analyzer was introduced onto our lab. So they had normal years ago. Now it's slightly prolonged. So you do the workup. As I mentioned, you obtain no conclusive answer sometimes. The mixing studies can be ambiguous. The PTT corrects several seconds, but is at or slightly above the upper limit out to 2 hours. The lupus anticoagulant becomes weakly. You start doing the lupus testing, you get vaguely positive results, and the normal factor levels allow the patients to be cleared. And I'd be very wary of calling these patients necessarily lupus inhibitor patients, because it just may be the vagaries of some of these assays in terms of what's going on. So I think I'm 2 minutes over. Maybe I'll have time for questions, but thanks very much.